Session.
Okay.
Okay, Amy Wood.
Hi, Amy Woods. Met a lot of you when you were in Portland. So I'm gonna kind of piggyback on Sarah. Sarah presented all the research, so I'm just gonna go through kind of a lot of things that we've already talked about, but kind of what it looks like in a when the patients come to us and what we want to do when they come through our door. So rehab goals in general, we have the preventative, like the survivorship that we've already mentioned. Restorative, where we want to try to get them back to the previous level of function, whether that's what they did physically, whatever they are doing for work. Supportive, so they usually see us long term. In oncology rehab, it's not usually when people come to orthopedic rehab and they're rehabbing the knee, they might only see that therapist for a certain amount of time. They have their knee surgery, their knee gets better, they don't need PT anymore. Frequently with oncology rehab, we see them long term. Sometimes, like I had mentioned, for many years because we want to surveillance them. So our goal is to kind of continue with them. Sometimes we might see them once a month long term. We might check in with somebody every 3 months, every 6 months, or just once a year. And then there's also palliative care. We have some palliative care therapists at OHSU. And so at that point, it's just what can we do to keep their quality of life high, keep them doing what they love to do. We might, they're in chronic pain. What can we do to help them function as much as they can? Because most likely we're not going to take the cancer pain away, but what can we get them to do for quality of life? These are just some of the outcome measures we use in general. The DASH, myself and Sarah Gang, who you guys know very well, we use the lymphedema impact scale a lot for our lymphedema our patients. So for Sarah and I, we do oncology physical therapy where people are coming in and it's more exercise, balance, education. Sarah Gang and I do lymphedema, where we might just see lymphedema patients only, or that's a side effect of their cancer treatment. And then based on oncology, I think we probably use the Pacific or the patient-specific functional scale a lot. And then if we're doing pain, then we have the low back scale and the neck scale. When we get a physical therapy diagnosis, these are some of any doctor can send us a referral. It's usually some kind of oncology diagnosis. It could be anything: lung, stomach, breast. That's the main underlying or the main diagnosis. And so the PT diagnosis, these are some of the things that we might see coming through our door, or these might be the things that we say what our diagnosis is for them. That might not be what the doctor says. They might just send us bladder cancer, and then we might treat some of these things. So pain, I would probably say, is a really common one. Posture, as we had talked about a lot, just from the deconditioning, loss of strength, what happens with treatments. Lymphedema, cording, which we had talked about, where you get from the different kinds of breast surgeries. So that might come more, the lymphedema and the cording might come more towards myself and Sarah Gang, because we're the two that do that. And these other ones, it could come to Sarah or Zerzan or I. Weakness, peripheral neuropathy, which is very common with chemotherapy, and loss of range of motion. So that's kind of in the big PT scope, the patients that we might see. And then it kind of depends on the types of surgeries they have when the evaluations come through. Like a lot of the breast cancer surgeons will send us, like most of their patients will come our way. And then what we want to look at is what kind of surgery did they have? Did they have a lumpectomy, a mastectomy? And did the doctor give us any special precautions, or are there any problems that we need to be aware of as far as metastases or anything like that, that we're looking chart review just to look at that stuff ahead of time. And then we also want to see, so frequently when we get the referral, we'll do a chart review before they come and see us. So we want to see, did they already have chemotherapy? Did they already have radiation? So they're coming to me with already having some of these things, or are they going to see me and then they're going to start chemo, or as radiation coming down the road? And then what kind of medication management are they on, as far as mostly with breast cancer, are they on hormone inhibitors? Prostate cancer, the same thing. So are they on those kinds of medicines? And do we have to be aware of the side effects of those, which are joint pain, fatigue, hot flashes? And then when they come to see us, what are they already doing? What did they used to do? So I really want to find out, what's your past? What kind of stuff did you used to do before you were diagnosed? Were you a triathlete, or were you sedentary and worked at a computer? So, and then what are you doing right now? Because a lot of times we'll see them before or when they've already been diagnosed. And what do they want to get back to doing? So then we can kind of figure out our exercise prescription based on, what they used to do. Frequently, when I have people who are very active and they come in, I tell them, you'll get back to what you used to be. This might be a new body that you're in, your new chemotherapy body. Usually it takes about a year, is what we say, from the time you finish all your treatment to get a baseline of what you might look like down the road. If you came in with strong muscles and you were very active, you don't lose that muscle memory. You'll get it back. You'll get back to what you're doing. It might just look a little bit different. So people who come in and who are very active, I think really appreciate knowing cancer and chemotherapy and radiation isn't the end of what they can or can't do. Or did you play with your grandchildren, or whatever the activity is? Usually people who come in who are active, have better recoveries just because they're active and I don't need to teach them how to do these things. When somebody comes in who's been sedentary, it's hard to get them to tell them, I got to walk, I got to do my strength training, I got to do my balance. You have to do a little bit more education. A cancer diagnosis does by no means mean you can't get back to what you used to do. And again, going back into that first time when I can just give as much education to that person from the get-go, just so they can walk out of my office, having some hope, like this isn't the end. And like you'll get back to what you used to do. These are some of the effects of surgeries that we can see, especially again with the breast cancer surgeries. They can get seromas or hematomas, tissue adhesions, again, from just the surgery itself or radiation, the postural changes. If they already came in as a computer person and they have breast surgery and radiation, most likely that's going to make them be even more rounded. Or the radiation, like we had seen the patients last time who had the tight neck and posture, that we want to be sure we at least talk to them about their posture, their ergonomics, because if they don't change those things, whatever may happen to them is just going to get worse over time. So frequently, I usually that first time talk about the importance of your posture. What is your head doing? Your head's like a 13-pound bowling ball. Is it forward like this? Are you going to be like this? And what are your ergonomics at your computer? If that's the only thing I can have them go away with, then that's great. Other things that can happen with all the different kinds of surgeries, just not with breast surgery, but they can get chest pain, rib pain, back pain. Again, if you have radiation on this side and it pulls your shoulder here, you can hurt all the way up here and over here. So reminding them that just because you have breast surgery, it's not just the breast. You can have all of these other things, neck pain, and a lot of times they'll be like, oh, no wonder I'm so sore. Oh gosh, yeah, you're right, my neck is sore, or whatever it may be. Difficulty breathing with any of these surgeries. And it's great that you focus a lot on chest rehab, because I think that's probably not something that we do, but our acute therapists probably do it like in-house, but they don't really see them very long. And then pain with, turning positions, they might not be able to sleep on that breast cancer side or that radiation side, or the, if they had any abdominal surgery. So just again, educating them on all these things. So like ahead of time, like these are things that you might see. Radiation, that's probably the one treatment side effect that we see long-term. They get through their chemotherapy, they go through their cycles. They might have, 3, 6, 8 cycles every 3 weeks. And then they get through it. They rebound, 3, 6, 12 months later, but radiation changes stay. We can't undo what radiation did. So I think probably the biggest thing I tell patients is this tissue is forever changed. It's it's not going to be the same. So when they go do their stretches and everything, that radiated side, they still have their range of motion, but it's going to feel different. It's going to feel tight, and you can't take that away. It's not gonna, you're not gonna lose your function, but people feel like they're like, gosh, I just did my stretches today. Why am I still tight? It's not the same. You can't really stretch out the radiated side or whatever it is. So I tell them that it's something that you have to do forever. You have to watch your posture forever. You have to just be mindful of what you're doing on that side. And I think once they realize the ebb and flow of radiation and what happens, then they're not wondering like, oh, why am I so tight? Is my cancer back? And also with radiation, you can have swelling, pain, that fibrotic tissue, especially with the head and neck patients. When they radiate here, I tell them that's not only here, it's everything inside your trachea, all of these things. So that's why they have hard time speaking, swallowing. And if over time they can't get food down, then they have to talk with their doctors. And then the scar tissue that can form. So that's why a lot of times I see patients for a long time, because we're constantly working on that scar radiated tissue, because I mobilize it, soften it, and then a month later they're like, gosh, I can tell I hadn't seen you in a month. I need to come in and have you work on it. I teach them to do it themselves, but it's not quite the same. With you can have somebody have their hands on you and help move things and loosen things up. And then the chemotherapy that we had talked about already. These are just kind of all the things that we've touched based on the fatigue, activity tolerance, osteoporosis, neuropathy, the weakness balance, cardiovascular, pain, chemo brain, chemo fog. So a lot of times I'll ask kind of that first time, because it might be the only time we can. Do they have chemo brain? Let them know that that's a real side effect. And a lot of times that can suck your energy. If you're trying to work, a lot of patients go work while they're getting their chemotherapy, and they're wondering why, gosh, I can't just make that work. I can't make that sentence, or I'm not really comprehending what you're saying to me. That if they're having any of those issues, we have speech therapy in our outpatient setting that they can go to for cognitive issues. So in our ENT world, the speech therapist there will work on speaking and swallowing. So if people are having problems with that, they have that speech therapy. And then in our department, we have the cognitive speech therapy who will help with that memory. And they usually do an evaluation, and then they'll give them strategies of what they need to do to help them stay working or whatever. And even if they're not working and they have problems making their grocery list, or they go to the store and they're like, oh gosh, what was I supposed to get? I can't remember. So those kinds of things. So we want to let them know that's a very real side effect. We don't know how long it lasts. Sometimes it lasts longer than others, but they can get help for it. The anemia, so I probably talk to people about their hemoglobin when they see me, if I see that they're low, and try to use that as a way to describe their fatigue, because a lot of times the doctors won't tell them what that is. And I show them like, this is where you are, and this is how low you are. So you don't want to try to ride your bicycle and try, because you have those people who feel like, I got to still play with my grandkids, or I got to still ride my bike, or I got to go for a run. And I tell them, whoa, you're low. You're this deep fatigue because your hemoglobin is low. You don't, until that starts to come up to a more normal range, it's not the time to push through. You really need to pace. And sometimes people are just chronically low. And if that's the case, then they kind of get used to what their low is, but letting them know right away, like what that means. And then they're like, oh, so then when they can look at their lab values, because they can pull up their lab values, then they can see like, oh gosh, I guess I was 11 last treatment and now I'm 8. No wonder I can barely roll out of bed or do anything. So then that way they can kind of keep track of that. Appetite, a lot of the head and neck cancer patients, sometimes they need feeding tubes because they can't tolerate treatment, or long-term they can't get food down. So are they getting their nutrition? Are they eating? Are they drinking? With the dry mouth that they get, they should bring their water bottles with them all the time. And so just checking in on their nutrition, and is that, are they getting enough nutrition? And then the skin and nail changes. Sometimes people get hand-foot syndrome with the chemotherapy. So are they having that? Are they having a hard time walking because they have it on their feet? And then just being sure that sometimes they know it's happening, but then they don't let their doctors know. And then when they let their doctors know, there's treatment for it. They can get cream and things for it. So just checking in on those things. So this is, again, what we would look for in the evaluation. So again, just piggybacking on Sarah's, the research of what we do. When they come in, sometimes, again, post-surgical patients is an infection somewhere, like when we'll look at the surgical site, being sure there isn't any infection or any dehiscence as the wound opened up. Is there seromas, hematomas, or anything that looks like cellulitis or anything that we need to be aware of to let the doctors know? What is their posture coming in? And again, what do we need to educate them on? Fortunately, I have a mirror in my room, and so I have them stand in the mirror and show them what they are, because, I show them what they are, but then when they see what they are, they're like, oh my gosh, I had no idea. My head was so far forward, or my shoulders were here. And then then they can visualize when they go home what to work on. Range of motion, manual muscle testing. In the lymphedema world, we do objective measurements where we'll just do circumference measurements here and then here at the wrist, and then we'll go up 10, 15, and then the cubital crease, and then we'll go 10 and 15. It's really quick, but as you know from Sarah Gang's SOZO lecture, if you can get that measurement, that's ideal, because that's the most objective measurement. And we can do, the SOZO is pretty quick too. But it's, I'll do that, pretty regularly, but it's a quick one to do the first time I see them. If I have time, I'll do the SOZO, but a lot of times if it's my first patient meeting them, it takes a couple minutes to put them into the iPad, that you put all you guys in. But if I have time to do all of this and that, I like to get that measurement too. So then I can see if we need to get compression garments going right then and there. If I can't do it the first time, I'll definitely try to do it the second time if they're high risk. And then again, just observation of different things, depending on what the patient had already coming in. These are the things I'm going to look at: their skin integrity, their incisions, their drain sites, and letting people know, like with mastectomies, they have drains in, and usually the drains are in for 2 to 3 weeks. And, when they're moving around, those drains are going in between the ribs. They don't realize when the drains come out, like how tender those drain sites can be long term. And so just letting them know, they're like, gosh, it hurts right here. And I'm like, oh, well, that's where your drain was. So, and just being sure there's no weeping or infection or anything in the drain. Again, what's the axillary incision? Is there cording, that fibrotic tissue? And a lot of times if they haven't started radiation yet, I let them know. Usually the radiation side effects come at about the 3-month mark. So they finish their chemo, they finish their radiation, they think they're all done. And then at 3 months, 6 months, they're like, oh my gosh, what is happening? Why can't I lift my arm up? Or why is my breast sore? Or whatever it may be. So again, if I can tell them that ahead of time, then when 3-6 months comes around, they're like, oh, that's what she meant. Oh, and then sometimes that's at the time that they'll have them come back and see me if they have it. Usually with lumpectomies, the breast gets very firm and sore. So just letting them know, like sometimes when you get big hugs, it might be uncomfortable. Sometimes laying flat is not going to be comfortable. Again, so certain things that it's not like the first time they're hearing it. Breast swelling. And if there's swelling, again, if it's bladder cancer, prostate cancer, gynecological cancer, they have swelling in their legs or groin or abdomen. Plan of care. So usually we're going to incorporate some kind of strength, range of motion. If it's a lymphedema patient, showing them manual lymph drainage that they can do themselves. But honestly, we probably put the manual lymph drainage lower because I want them to move. Exercise moves lymph. So I want them, if they can't like go for a walk, I want them moving their arms or moving their legs to help pump that fluid. Then do we need compression? Talk to them about that, and lots of education. And what's their home exercise program going to be? Like I said, it's usually walking. I'm a fan of the sit to stand. And like I said, maybe just like a row, or maybe this, just a couple things that when they go home with, they feel like, okay, she told me to do this a couple times a day. I can tie it to my door, easy. I can fit it into my day. Or I can just stand up and sit down from a chair. I can do that whenever I'm sitting. Or if I'm going to the bathroom, I can just do it from the toilet. Um, skincare, again, if it's a lymphedema patient, and then teaching them the self-manual drainage. These are just some of our lymphedema and overall functional goals. We want to be sure they can manage it at home in regards to exercise, compression, that manual lymph drainage, and that they're independent doing it. Are we able to decrease their pain? Again, we don't really focus on the number of pain because it's can be so variable, but is your pain improving? Are you able to do stuff with the pain? You know, how functional are you? Again, are they independent with their compression garments and their range of motion and muscle strength? So if they were weak, and then getting them back to whatever it is they want to do, anything could, whatever their improve their quality of life. Again, this might be treatment. Again, so the treatment on evaluation is quite different than the treatment when we see them the second time, because treatment on evaluation is all this education that we already covered. The lymphedema, fatigue, sleep, the peripheral neuropathy, pacing, the upper arm. I think I have a slide coming up on what that is. Importance of exercise, again, that we've saw all of the research. It is okay to exercise with an oncology diagnosis. You just have to be mindful of all those other things that we talked about: metastases, blood work, surgeries, are there post-op restrictions. And so just the importance of exercise, it can, you know, preventing weight gain. That's, I mean, if you're on chemo and you're getting a lot of steroids, unfortunately, a lot of my patients say, gosh, I had cancer. I thought I was going to get skinny, but they, you know, either don't lose weight or they gain weight because of either the inactivity and all the medicines. And sometimes they just get bloated with just swelling in general. But I think that's more importance of exercise in general. Exercise helps with the weight loss for people over the 25 BMI, bone density, chemo brain, joint pain, and lymphedema. So again, just reiterating exercise. Questions so far before we go into this? This is going to be just some of the exercises that I give patients. I know it's a ton of stuff, but all stuff that you guys, right?
Do you have any indication of the hemoglobin level that we will not prescribe exercise? No.
It was with yeah. Yeah. So same thing as Sarah's. Yeah. Yeah. That's kind of what we use. And I think that's what the research that we found, 8 to 12 is the range that we look at. So if a patient comes in to see me and they have peripheral neuropathy, what I'll educate them on, the things that can help. I'm not going to take it away. Hopefully once they finish their chemotherapy, it will get better. Sometimes it does, sometimes it doesn't. Sometimes people have it long-term, but I find a lot of times different oncologists say, depending on the 3, 6, 9-month mark, it might improve. But if what they can do to help, like with peripheral neuropathy with on their feet, it's like a mineralized, it's kind of like menthol-y. If they can just rub it on their feet and stretch their toes, can help just desensitize the feet. That can help the brain not see as it feels like the nerve sensation is as intense. Stretching out the calves is very important. If I have peripheral neuropathy and I can't feel my feet, I'm going to walk a lot more gripping kind of my toes, which that will then make my calf very tight and it will actually make my feet very tight. If they've had chemo affects the tendons, so it's going to affect the Achilles tendon the most. So we want to be mindful that they stretch out their calves a lot and their feet. So a lot of times they don't realize it. They'll say like, gosh, it feels like I'm walking on clouds. And then they don't realize how tight their calves are until we do some of the calf stretches. So I give them, lots of calf stretches. Compression socks can help again, because it's desensitizing. Sometimes the chemotherapy, their legs get swollen anyway, so compression can help with the lymphatic, flow, and just help with the sensation of that pins and needly feeling. Tell them that because they can't feel their feet, they should be inspecting their feet, looking at the bottoms of their feet, in between their toes, because they might not know that they stepped on something or they have a cut or something on their feet. And just to be sure they wear good shoes inside and out, inside and outside. So that's kind of what I'll give them. And if they have the peripheral neuropathy, if they have that, they'll come back and see me, not to treat the peripheral neuropathy per se, but I'm gonna help them get better with what that does to them, because they're gonna most likely have poor balance. If I can't feel my feet, I'm gonna probably have, feel like I'm not stable when I walk. I might be tripping, I might have falls, so they're gonna come see us to help improve their balance, improve their strength. I tell them, I'm not gonna make your neuropathy go away. Hopefully we can make it get a little bit better, but I want to be sure that you can function as high as you can with it. And what do we need to do to help you do that?
It's me. I'm interesting in the first line, the mineral ice. Why it should be mineral ice?
What's the meaning of mineral ice?
It's like it's a topical, maybe like tiger balm or something they rub on their feet. It's like, it's menthol, and they rub it on.
Oh, like a
Tropical.
spray or cream.
Tropical.
Yeah, they can get it at the grocery store.
That cool effects.
I think it's the ice from the mineral water. Okay. That's why I go back home and then take a mineral to the refrigerator.
Cool effects.
เหมือนกันไหมเห็นไหมพี่สงสัย เห็นเราไปทำจาก mineral water. Okay, I see. Just same as everybody. That's right. Interesting in that.
Yeah, so whatever thing was similar that you have, that when they rub it on, it feels cool. So it feels soothing and it desensitizes them, so they don't feel that pins and needles so intensely.
Vertical muscle stimulation.
Like a E-stem? Is that?
You mean that the patient has a motor neuropathy, muscle and causing muscle weakness?
Oh, yeah. I mean, if they can't, is it the same thing that?
So NMES.
Yes.
Different
Oh.
than
It's
EMS.
not only sensory, it's a motor,
Oh,
So
motor
as long as
neuropathy.
as long as, they can feel what you're doing. Like you're contracting the muscle to get it strong, but they can feel it, so they're not, injuring,
Yeah,
the skin and.
because NMES, like the neuromuscular is usually to the max tolerated setting. So if they have a sensory deficit, you might be setting it too high and they can't feel how high it's setting. So you don't really do NMES on an area of impaired sensation. So, but if they don't have a sensory deficit, like proximally, probably would be okay.
ไม่น่านะบางทีมันเป็นเฮปไรนี่
in like a first right? So maybe in, so maybe we can use the electrical stimulation. Like a 10, maybe 10.
Yes.
Yeah.
But yours is NMES, yeah.
Yeah, yeah.
Yeah, but if there's a nerve sensation, don't use.
Yeah, yeah.
Yeah.
If painful, so okay, maybe use the electrical for improve the math.
Right.
But I think most of the case, I think they are reversible for the mother. If it's from the medication or from the chemotherapy, so I think it's
Yeah, it's,
reversible, just wait and see.
right,
Better than if you provoke pain,
yeah,
then that
right.
another problem.
Well, and also like we'll see more often motor deficit would be like if they have spinal metastases. Like if it's a motor deficit, it's often different than just a chemo-induced peripheral neuropathy. There may be another more proximal cause.
Except you found that like with sleeping and compressive neuropathy
Yeah.
that need to preventive.
Yeah.
The nerve
Yeah, exactly.
so we develop muscle weakness and control extension. So it is only how long I have to wait and how long it's really covering.
Okay, please.
Repeat it one more time.
I mean, after surgery, the choose scan. It show the nerve involvement, so the patient can develop muscle weakness. So
Nerve involvement from the surgery or from the cancer.
So you tell me how long the recovery time for muscle, how.
Well, that depends on treating the cancer first, right? And then in terms of peripheral, like a motor deficit, we say 1 millimeter per day is usually the rate of nerve regeneration. So that's, depending on what region is affected, the length of the nerve, that would be the rate of recovery.
Kind of a metaphor for slow.
Yeah.
It's gonna be slow.
Yeah. And not always complete recovery. Like it depends how long the nerve was compromised, the extent to which it was compromised.
Any other questions?
That's one thing. If this patient happen, okay, during the education, when you see this patient first, they want to know this is okay. Patient need to know that how the recovery time. That's why the education that come from you.
Yeah.
Okay, that how to explain to the patient that they should accept this duration. How do they want to know that? Okay, this is take a time, but I want that happen early.
Yeah. Yeah.
Please give your opinion
Yeah.
if this happen.
Yeah.
Well, you kind of talked to them about the chemotherapy and the process of weeks that they have. Like if they are coming once a week for 3 weeks, that's gonna take time. And that I kind of go back to what they were when they first came in. Let them know that you will get back to what you used to be. Again, it might look a little different, but you're gonna have good days and you're gonna have bad days. And usually in the big scheme of things, a year from the time they finish the last thing, so they might have chemotherapy, then they might have surgery, then months later, they might have radiation. So that last day of radiation, I tell them from that day for a year, there's going to be lots of stuff happening. And as long as you be mindful of all these things that we've talked about, you will get there. But it's going to be a rough road. But I feel like if they know all of these things that are coming, that could come, not everybody, but that they could come. When they do come, they're like, oh, that's what they meant. And okay, she said this, and this is what I got to get through this. And so usually they kind of go through one thing at a time. Like you get through your chemotherapy, then you get through this, then you get through this. And I just let them know, yeah, you want it done today. We all do, but this is the reality. And again, just kind of positive reinforcement, really letting them know, like, you will get back to what you used to do eventually.
I have one question about the breast reconstruction. DIEP flap surgery. Do you have any patient performing that?
We used to have a surgeon that did that, and then she hasn't been there for quite some time, and so we are supposed to be getting a new surgeon at some point, but right now we don't have one in-house.
Because here we have one surgeon start to do this and consult the rehab. So I wonder about the rehab role in this case because I don't think the advantage is more than disadvantage in this case.
So usually with the deep patients, it's not so much, you know, the upper rehab is pretty basic as far as once that's okay to move, we still want them to do range of motion, we
Mhm.
still want them to do all of these things. But the biggest limiting factor with that surgery is the abdominal. Our surgeons back home, a lot of them don't want you to, you have to kind of be hunched over for 2 to 3 months. And you can't walk a lot. So it's not so much what they did up top, it's the recovery of the abdominal area. And so each surgeon there has their own restrictions, but they're pretty significant as far, but they still walk. I'd probably say that the main thing they do is walk. But then they can't do a lot for
No.
3 months. So that's a long recovery, that surgery. But again, all of these other things still play into the rehab. We used to see them a lot, but we just don't have that.
Because in my opinion, I think the early phase don't have any rehab role. Because the patient can walk.
Yeah.
Right, it'll just be the education piece,
Mm.
like, and just being sure that they're stretching their arms, their neck, watching their posture, their ergonomics. So that this doesn't get tight and then they end up with neck pain, back pain, rib pain. But then, yeah, they are very limited here. They're only walking. There's not much that we can do. But still good. You still want to see them to give them all this education. But again, every surgeon's gonna have their own precautions or restrictions for
But
for
I'm
that surgery.
scared about the artery connection
Mhm.
because it's a very small blood cell.
Yep.
If the patient moves shoulder too much,
Mhm.
maybe the connection break.
Well, so each surgeon will have their upper body restrictions, like when they might not want them to go over 90 for a certain amount of weeks. But usually their restrictions are less above than below as far as the time frame. But yes, there will be restrictions. But again, that'll be surgeon, based on each surgeon, but they might not want to have them do any range of motion for a set amount of weeks. But then once those restrictions are lifted, you want to get them doing all of these things. But again, it's surgeon dependent. But they should, eventually I'd probably say usually 2 to 4 weeks. But the abdominal, yeah, definitely can be up to 3 months.
3 months.
Yeah, sometimes where they can only walk.
But then seeing them after,
Yes,
that's important, like,
right.
the later phases, that's when it's really important to get them in regularly. Because they'll have all these restrictions in mobility and strength because of the precautions. So then after 3 months.
Yeah.
Yeah.
So that's probably when we'll do a lot more.
After 3 months.
Yeah.
Okay. Possible, maybe set the pre-rehabilitation program.
That would be an ideal. Yeah.
But post op waiting until 3 months.
But that would be an ideal prehab patient we would want. Yeah, for sure. And that would be one you'd want to get them strong. And because if they aren't already walking and doing these things, we got to get them to walk because that's the main thing that they're going to be able to do for a long time. Any other questions? So this is like what we usually will give when they're less than 2 weeks, but this is not a deep flap patient. Deep flap. So just working on, because if they have drains in, most of our surgeons don't want them to go above 90 because for the drains. So we just might be working on shoulder shrugs, range of motion, anything down here that we can do to be sure that they're moving. And again, lots of education on the posture because they don't realize when you can't move, you get really guarded. And then when the drains come out, if you haven't already been moving something, you can get more stiff. And then that can lead to cording and other things. So we just kind of want to keep them anything below 90 the first 2 weeks. And then after that, we give them regular stretches. So I think we had gone over these in Portland, where it'll just be like reaching overhead, arms here, snow angels, wall walks using the walls. And so a lot of times and then laying down with their knees bent, hands behind their head, snow angels, and then arms over their head. I usually tell people their stretches they can build throughout their day. You're at work, you reach your arm up a wall, you find a corner, you work on this, and you build these in throughout your day. So you're stretching. And then when you get home at night, maybe you take 10 minutes to do the laying down stretches. Because again, people, have time. They're usually limited on time, but a lot of these stretches and posture they can do all day. And then as far as the lymphedema goes with breast cancer, so they have surgery here, radiation. So the lymphatic vessels are damaged. So lymph can start to back up in the arm or if it's in the groin, and then they can get lymphedema. And so I usually describe it to them. I usually tell them what their risk is. If they've had 4 nodes or more with radiation, their risk is high. If they don't have that, their risk is low, but I usually tell them there's always a risk. I mean, who knows down the road, even though you're not the statistic, you want to be mindful that these things could come up. And sometimes if they're not high risk and then 5 years down the road, they're like, gosh, why is my arm swollen? It could be a metastases in their axon. And then it's something else. So they're always mindful of, okay, even though my risk is low, and then I usually describe it as lymphedema it feels like a heaviness and a fullness in your arm. It's not pain. It's not sharp shooting. It's not neuropathy type pain. It's like if you have a sponge on your sink and it starts to fill up with water, the sponge doesn't get any bigger, but it gets heavy. So my arm is going to feel, as the fluid is building up inside, my arm is going to feel heavy. Then when the sponge can't take any water anymore, I'm going to get swollen. So my rings might get swollen, my watch or my sleeves might get swollen. So then that way they can always be mindful of something is happening in that arm. And then usually we tell them, you want to come in and see us, as quickly as possible. And that's when we'll definitely do the SOZO measurement. So then we can get an objective finding right then and there. Do you have lymphedema? Are you at risk or do you not? And then that way, based on those findings, we can get compression. With lumpectomies, compression bras are probably the most common thing that we would recommend post that kind of surgery. But again, we're looking for, are they telling me their arm feels heavy or full? Are they showing me they're swollen? And then we'll take those circumference measurements, we'll do the SOZO measurement, and then based on those findings, we'll determine, their frequency of care. Complications, if lymphedema stays somewhere for a long period of time, it can make your arm very thick, hard. You're at risk for cellulitis, infections, wounds. So we want to be sure that they're checking for any of those things. Skin changes can happen. Pain, but again, it's not, they describe it a little bit different. So if somebody's telling me, wow, I've got like electricity going down my arm, and the doctor gave them a lymphedema diagnosis, but they're telling me other things. And I'm like, well, that might not be lymphedema. I need to see, is it something else going on with a nerve or anything else? So ideally with a lymphedema patient, in the real world, I guess we don't really do this at OHSU, but it's more in European countries, a lot in Germany. They do complete decongestive therapy where a patient will come in, again, if they have lymphedema, and they'll get bandaged. And then they'll come back and they'll do that every day for 2 weeks, 5 days a week for 2 weeks. We just don't have that capacity to do it. And honestly, nowadays, because surgeons are so specific where they can go in and they can just take what they need. Back in the day, they would go in and just take everything. So, and they wouldn't educate people on lymphedema, and you would see women come out with just really big arms. But now if I can move a lymph vessel away and I can just take only what I need, the surgeries nowadays are just getting more specialized that we don't really see these patients that much. Plus, they're getting to us quickly. We want to see them day one. That's why we want to catch lymphedema, because it's reversible in the first 2 stages of it. I can keep it from turning into anything. Chronic stages, there's nothing, we can do. We have to maintain it. So they would bandage, and then, once you bandage and you reduce the limb, we want to reduce it to where we can get you a home sleep. But what we do is more the hands-on manual work where we're doing the drainage, exercise, stretching, and education. So if somebody, let's say, isn't very mobile, and can't walk and do a lot of exercise, these are some lymphedema exercises that we have them do. Your biggest lymphatic duct is in the belly. So I usually talk about belly breathing. And when you belly breathe, you're pumping that biggest hose in the system that helps drain everything. So if somebody's at work or somebody's at home, they can do this lymphedema exercise to help. Again, we want to pump things. And when I usually explain to them, lymphedema, there's no valves. So in order to move lymph, I have to move. So just me doing this, I'm moving my lymph here. Doing this, I'm moving lymph. So I don't have to go for a long walk. These are things that I can do. So we educate them to, most of these things are 10 times. So they'll like belly breathe in and out of their belly. And then I have them do like 10 head nods, 10 head turns, and then they tilt their head. And I have them just work their way down where they'll do some shoulder shrugs. They'll lift their arms up and they'll bend their elbows here, they'll bend their wrists. And then when it comes down to the legs, they just do some marching in place. And then they straighten their legs and then they come up and down on their toes. Things that they can just do sitting at work or at home or in their bed. Chicken wings, yep, anything. Just you want them moving. So just pumping. And that's why walking is so good, because when we walk, we're moving the lymph. Not only is our calf moving, but we're moving our feet. There's lymph nodes a lot behind the knees and at the ankles. So if we can just pump those, we're going to help drain fluid. And these are just some contraindications for decongestive treatments. You don't want to, if there's an acute infection, renal failure, cardiac edema, acute DVT, acute bronchitis. Relative contraindications are malignancies, bronchial asthma, history of hypertension, and congestive heart failure. Manual lymph drainage contraindications, you don't ever with the DVT. Compression, you don't ever with cardiac edema, arterial disease, spasticity, infections, stage 2 CRPS. Relative is hypertension, cardiac arrhythmia, paralysis, diabetes, a malignant lymphedema, and then CRPS. And these are just my, these are my references. So, questions?
One question that I ask you is,ยังไม่มีใครถามเลย Okay. Do you use the PSFS for the cancer patient?
Yes, I use that a lot.
A lot.
Yes.
Okay. If normally in MSK or in neurological, we set at the first time, and then maybe 1 month on another, we'll change it again.
Mhm.
But for the cancer patient, it's the same as another kind of disease or is different?
So there was no specific literature to validate the use of the patient-specific functional scale for the oncology patient in particular. So I would say probably go with the guidelines for musculoskeletal or neurological. Yeah, there was no specific literature regarding for cancer patients.
Because of, I asked this question, when the patient is mood change or physical change, or it depends on the mental and depend on the physical. That's why the patient is cannot, or the PT or OT cannot reach the goal of the patient. That's why PSFS have to change or not
Yeah.
if we cannot reach the goal.
Yeah, well, and that's why I guess you choose like a patient specific, like in the dialogue, you say, what are things that you want to improve on? Maybe they won't get a 10, right? But clinically significant differences, I believe, like 2 points. Yeah. So even if they don't get to 10, if they go from 2 to 4, that's clinically significant.
I
Yeah.
feel like, if the patient's changing, then it's time, I want to know, like, tell me everything.
Yeah.
And are you talking about updating the numbers or changing the goals or both?
The goals.
Changing them, or measuring them?
I mean that if the patient needs to ambulation from bed to the garden about 50 meters,
Yeah.
but the symptoms that cannot
So you want to,
cannot reach the goal.
so you want to change the goal.
Yeah.
The PT said that from the patient's need, right, the PSFS,
Yeah.
that, okay, 50 meters, but many weeks that when we training, he cannot reach the goal.
Yeah.
So you want to change it.
Yeah.
Yeah.
I don't think there's a time frame for that. If it needs to be changed, then change it.
Yep.
Talk together.
Exactly.
Yeah.
Like collaborative. Yeah.
Okay.
That might be when you first see them, like a appropriate goal. But then they go through chemo and they didn't have any clue that maybe they end up being hospitalized a few times and they got really, really sick. And then that's just not a realistic goal anymore. And now you have to look at what they're presenting to you today and change it to something that might be, and it might be something totally different. That might not be appropriate at all. You might be able to change the parameters and not maybe walk as far, or you might just, that might not be it anymore.
And if your treatment plan is really changing, you tell the doctor, just CC them in the notes. Treatment plan is changing.
Have a question about compassion, pneumatic pump or band-aid, what kind of better for daily use? Better for daily, or maybe pneumatic band-aid. Yes, we have, let's have the Sarah can show me about the daily use, right? Pneumatic and maybe.
Yeah.
Time, you use the pneumatic pump like a sequential.
Right.
Yeah.
We, Sarah and I, feel like the pumps aren't as effective as exercise, as moving. Sometimes, not for everybody, sometimes certain individuals need it. It's not gonna be our first line. But if other things aren't working great, then we might go down the pump route. But there's another pump that she was talking about where you're active. Most of these pneumatic pumps, you just lay in bed for an hour and it pumps. And you'd be better off getting up and moving around if you could. Again, if somebody can't, then they need that. But the pump she was talking about is one that you put it on and then you actually are walking around doing stuff with it on. Yes, that's totally different. And that's a newer thing. That we're, again, trying to use more, but again, it's not going to be our go-to. Our go-to is going to be exercise and moving and stretching, and then the manual drainage, and then I would probably put the pumps at the bottom. Again, but everybody's different. There might be somebody that you put the pump at the top, but for, that they're can't get out of bed or, for various reasons, but they're cumbersome, really hard to put on. Most people don't like them. They take an hour. So, people, and it takes, and, unfortunately, in the US, they're very expensive and most insurances don't cover them. So
What about
It's a sign, it's just very-
Yeah, it's a sign.
no, we need more money?
Yeah.
For the lung cancer or lung surgery, recommend what or specific test for the lung function. By the lung function after surgery.
Probably any of the functional measurement tests we would use, yeah, yeah. And it might be a 2-minute walk test instead of a 6-minute, or it might be, a 5-second sit to stand, or, any variation of that. There's another hospital in town that does pulmonary rehab, so those patients might go to pulmonary rehab, where they might have a different set of, function, testing there. Yeah.
In the patient non-small cell lung cancer undergoing pulmonary radiation have problem pneumonitis. How to recommend for prevent and manage patient lung cancer with pulmonary radiation induced with pneumonitis.
That patient would probably go to the other facility for pulmonary rehab. It would be my guess. Where we are in our setting, we wouldn't treat like the new, that. But they would probably need like the chest therapies that you provide here.
Respiratory therapies.
Yeah. But if it was more like, dyspnea, then it might be saying like the functional measurement tests or outcome measures.
Okay, Jenny, this time for the, a little bit.
Any questions from online at all?
Good for you. Your question.
Is there any question from other sides? Okay, if no, we're gonna take a break for 15 minutes, so we should come back by
It's okay, 20, yeah, 20 minutes, okay.
11, everybody.
Talk fast.
It's time for you to prepare yourself.
All right.